He had no idea he was abandoning the former chief of ophthalmology at Boston Medical Research Institute, the woman whose medical authority could revoke vision care certifications across 8 states. Whose helpless elderly patient persona he dismissed while rushing to his pharmaceutical sales meeting would soon transform into the eye care authority who could watch from her quiet home office. As his groundbreaking vision therapy clinic lost its federal funding and state licensing through legitimate medical board violations, all because the ambitious optometrist who assumed his 70-year-old mother needed a ride home from routine eye appointments never bothered to ask why major hospitals throughout New England treated her like visiting royalty, why medical equipment companies somehow always provided his practice with cutting-edge technology at wholesale prices, and why the most successful vision centers in Massachusetts mysteriously received flawless inspections and seamless insurance approvals that other practices struggled to achieve even with teams of administrators and months of paperwork. Before we dive into this incredible story of medical abandonment meeting healthcare authority and the vision care empire my ungrateful son never knew existed, make sure to hit that like button. Drop a comment telling me about your worst experience with family members who treated you like a burden while benefiting from your professional connections. And subscribe so you never miss stories like this one about what happens when adult children assume elderly parents are helpless patients, only to discover just how catastrophically wrong they can be when family disrespect meets medical expertise that could transform their thriving practice into a very public lesson about respecting the woman whose ophthalmology innovations helped build New England's premier eye care network. My name is Dr. Helen Margaret Thornfield. I'm 70 years old, and this story begins on April 22, 2025. When I made what seemed like a simple request for my son to wait for me after my routine eye appointment at Springfield Vision Center, a basic family courtesy that would reveal my only child's true character and teach him the most expensive lesson about dismissing elderly mothers whose quiet career in medical research and ophthalmology administration had been ensuring that Massachusetts' most prestigious vision centers received perfect state inspections, seamless insurance coordination, and the kind of medical board approval that determined whether ambitious eye care practices received federal research grants or disc overed that vision therapy licensing required, demonstrating respect for the medical expertise that created their exclusive healthcare opportunities. The comfortable life that Dr. Marcus James Thornfield had built around his stunning $1.2 million vision therapy clinic in downtown Springfield, which he considered evidence of his innovative medical approach and entrepreneurial brilliance, was actually supported by the kind of seamless medical board coordination and federal research grant management that I had been developing and maintaining throughout my entire 43-year career in ophthalmology and medical administration. The perfect inspection results that had enabled his rapid clinic expansion across 3 locations, the exclusive access to experimental equipment worth over $400. That distinguished his practice from standard optometry offices, the comprehensive insurance approvals that provided financial stability during his aggressive business growth strategies, and the federal research partnerships that ensured cutting-edge treatment capabilities all depended on the sophisticated medical authority and healthcare network coordination that required exactly the professional knowledge I had been developing for over 4 decades. Marcus's Springfield Vision Therapy Center had become the crown jewel of Massachusetts eye care innovation, featuring state-of-the-art diagnostic equipment that most practices could only dream of accessing. Specialized treatment rooms designed for advanced vision rehabilitation programs and research facilities that attracted medical students and ophthalmology residents from Harvard Medical School, Boston University, and Tufts University. The clinic's reputation for handling complex vision disorders and breakthrough treatment protocols had made it the preferred referral destination for neurologists, pediatricians, and family physicians throughout Western Massachusetts who needed advanced care for their most challenging cases. The success metrics that Marcus proudly displayed in his clinic reception area included a 94% patient satisfaction rating, Recognition as New England's most innovative vision center by the American Optometric Association, partnerships with 12 major hospitals throughout Massachusetts and Connecticut, and a waiting list of over 800 patients seeking appointments for specialized vision therapy programs that other practices couldn't provide. His clinic processed over $2.8 million in annual revenue while maintaining profit margins that exceeded industry standards by 340%. Creating the kind of financial success that distinguished premier medical practices from standard neighborhood eye care offices. But what made Marcus's professional achievement particularly remarkable was his development of proprietary vision therapy protocols that had been featured in 6 peer-reviewed medical journals, presented at international ophthalmology conferences in Geneva, Toronto, and San Francisco, and adopted by over 40 vision centers throughout North America seeking to implement similar treatment methodologies. His innovations in pediatric vision rehabilitation had attracted research grants totaling $1.6 million from the National Eye Institute, creating opportunities for clinical trials that position his practice at the forefront of vision care advancement and medical research coordination. To understand how my son Dr. Marcus James Thornfield, a 44-year-old optometrist earning $340 annually plus substantial research bonuses from experimental vision therapy programs throughout Massachusetts ended up watching his vision clinic lose its federal funding and state licensing within 96 hours of abandoning his elderly mother at a routine eye appointment. You need to know who I was before my carefully maintained image as a simple retiree with vision problems concealed the medical expertise and healthcare authority that had elevated me from entry-level research assistant in 1978 to chief of ophthalmology at Boston Medical Research Institute, a position that required federal clearance oversight and system access that determined medical equipment allocation, research funding approval, and practice coordination for over $280 million in annual vision care research throughout Massachusetts, Connecticut, Rhode Island, New Hampshire, Vermont, and Maine. For 43 extraordinary years, I was Dr. Helen Margaret Thornfield, dedicated medical professional at one of New England's most prestigious ophthalmology research institutions. Starting as a junior lab technician when computerized vision testing was revolutionary new technology and advancing through every level of medical responsibility until my retirement in 2021. As Chief of Ophthalmology with signature authority over cutting-edge research allocation, medical board coordination protocols, and federal funding systems that most people never understand or appreciate, my career had encompassed every aspect of vision care administration. From basic patient documentation to complex multi-hospital research strategies that determined whether medical practices maintained their federal partnerships across decades, whether patients received appropriate treatment coordination, and whether healthcare networks achieved the innovation and safety standards that distinguished successful vision care distribution from medical mismanagement and regulatory violations. The scope of my medical responsibilities had encompassed managing research relationships for 78 of New England's most advanced eye care facilities, coordinating with federal health authorities who required accurate vision research data for policy development, implementing treatment protocols that balanced patient outcomes with medical innovation requirements, designing research systems that synchronized medical documentation between ophthalmology institutions, federal regulatory agencies, and private insurance companies, and troubleshooting medical complications that could affect everything from individual vision treatments to multi-hospital research strategies that influenced regional healthcare innovation and patient safety standards throughout the northeastern medical community. During my 5 decades of distinguished medical service, I had personally overseen research coordination for over $520 million in vision care innovations, supervised relationships between 127 different eye care facilities across 6 states, collaborated with federal health officials who required accurate regional data for vision policy analysis, and managed funding protocols during healthcare crises that required immediate coordination between state ethical boards, federal oversight bodies, and private healthcare companies to ensure patient protection while maintaining research integrity and medical compliance requirements that balanced treatment access with innovation standards optimization and federal safety protections. The transformation that I had witnessed and managed during my career was extraordinary, from manual patient record systems in traditional medical file storage to sophisticated digital platforms that could instantly verify patient eligibility, insurance status, equipment availability, and research coordination across global networks that connected individual vision treatments to international ophthalmology research systems. I had been personally responsible for training over 230 for medical professionals in research protocols, federal compliance procedures, and healthcare coordination techniques that required both advanced medical expertise and deep understanding of healthcare law, federal safety regulations, and patient protection requirements. My position as Chief of Ophthalmology meant that I possessed what was essentially master-level access to the New England Regional Medical Research Network, the ability to authorize equipment transfers, coordinate multi-hospital research allocation, implement emergency patient protection protocols, and evaluate medical conduct that could instantly transform someone's healthcare access from guaranteed service to comprehensive medical review require. Extensive network evaluation and federal compliance verification to complete through proper medical channels and documentation processes. The Boston Medical Research Institute, where I had spent my entire career, wasn't just a regional healthcare facility, it was the exclusive provider of coordination services for the Federal Health Administration's New England Regional Integration Network, managing vision care research for over 340 municipal healthcare systems, 67 major metropolitan medical areas, and coordinating research integration with 189 different county health departments across 6 northeastern states. Our systems processed over $4.8 billion in annual medical research transactions, coordinated equipment distribution for over 890 different hospitals and medical organizations, and maintained the infrastructure that enabled platforms like federal research databases, local vision centers, and medical equipment manufacturers to provide effective healthcare management and patient coordination for thousands of New England families. But perhaps the most significant aspect of my medical career was my role in developing and implementing the automated healthcare coordination protocols that determined how vision care equipment flowed between research allocation, hospital inventory systems, patient treatment networks, and medical delivery coordination. I had personally written specifications that guided equipment distribution for dozens of New England's most advanced eye care facilities, established coordination procedures between state medical agencies and federal health authorities, and created evaluation protocols that ensured consistent, appropriate medical allocation across generations that served both individual patient needs and regional healthcare distribution requirements. The medical infrastructure that I had helped design and implement served as the model for national vision care research, with healthcare authorities in other regions consulting our protocols for guidance on equipment management, patient coordination, and compliance implementation that balanced treatment expectations with medical network optimization. My expertise had been featured in medical journals including the American Journal of Ophthalmology, New England Journal of Medicine, and Journal of Medical Research Administration, and consulted by healthcare networks throughout North America who wanted to implement similar research systems and automated protocols that served both individual treatment needs and multi-generational patient relationship monitoring requirements. The innovations that I had developed during my career included automated integration protocols that synchronized patient data between county health databases and federal medical systems, compliance algorithms that protected patient privacy while maintaining treatment accessibility, error detection systems that identified research irregularities before they affected family healthcare access, and crisis response protocols that maintain system stability during equipment failures or cybersecurity incidents that could affect millions of patient records and billions of dollars in medical research activity. These innovations had been adopted by medical facilities throughout North America, implemented by federal health agencies for national database modernization, and licensed to international healthcare firms that wanted to implement similar integration systems and compliance protocols for medical management in European Union countries, Canada, Mexico, and Pacific Rim nations seeking to modernize their healthcare systems and improve research coordinate between government agencies and private medical organizations. The consulting contracts that I had negotiated with federal health agencies included ongoing administrative support for database modernization projects, emergency response coordination during system failures that affected multiple states, compliance, assessment and enhancement for federal medical databases, and strategic planning for next-generation medical technology that would improve system integration and reduce healthcare management costs while maintaining accuracy and security standards that protected both individual patient privacy and federal medical monitoring capabilities. Marcus's comfortable assumption about his medical success and advanced vision therapy practice, which he considered evidence of his innovative approach and entrepreneurial expertise, was actually supported by the medical network privileges and healthcare coordination that I had been providing throughout his entire professional career. The seamless inspection approvals that had enabled his clinic licensing, the exclusive access to experimental equipment that distinguished his practice, the priority research partnerships that ensured cutting-edge treatment capabilities, and the comprehensive insurance coordination that protected his business investments all depended on the kind of sophisticated medical relationships and healthcare network management that required exactly the expertise I had been developing for decades. The seamless medical experiences that Marcus had always enjoyed weren't natural consequences of practicing in affluent Massachusetts communities or working with premium healthcare organizations. They were the direct result of medical preferences and administrative advantages that I had been providing through my coordination authority and system access. Marcus's comfortable practice had benefited from perfect medical board coordination, seamless equipment distribution processing, and enhanced allocation management that attracted maximum federal support because I had personally implemented research protocols that ensured optimal visibility and compliance accuracy. The smooth inspection processes that had helped Marcus during his clinic expansion phase 5 years ago had benefited from expedited verification and automated compliance checking that reduced approval timeframes and prevented common administrative delays that affected most medical applications. The comprehensive healthcare services that enabled his comfortable practice reflected distribution coordination that I had maintained between county health systems and state medical databases, preventing the service gaps and administrative complications that could have significantly affected his access to research funding and federal equipment programs. The excellent medical board relationships that supported his practice development, the research programs that provided revenue growth, and the healthcare infrastructure that supported his professional reputation all depended on medical coordination and board management that required exactly the kind of administrative expertise and federal coordination that I had been providing throughout my entire career. Marcus's success with Springfield Vision Center and his ability to pursue sophisticated treatment innovations despite substantial research investment risks had been supported by the comprehensive federal backing and medical coordination that I had been managing through Massachusetts healthcare infrastructure, the emergency funding facilities that had helped him secure his experimental equipment, the research programs that supported his continuing education and professional development, and the medical services that maintained his professional image, all depended on healthcare coordination and board management that I had been providing without his knowledge or appreciation. But the most ironic aspect of Marcus's comfortable assumptions about my limited understanding of modern vision care was that his own success in innovative eye therapy relied on medical management principles and healthcare coordination techniques that I had pioneered in ophthalmology administration and had been teaching to medical planning professionals for over 2 decades. The seamless patient experiences that he provided to his clients used coordination protocols and research integration design principles that I had developed for medical facilities and had shared through professional conferences and administrative training programs throughout New England. The sophisticated practice that Marcus had achieved through his medical expertise and business development was entirely dependent on the kind of healthcare infrastructure and medical board coordination that I had been developing and maintaining throughout the vision care industry. His beautiful clinic served as his primary professional address because its perfect medical services and accurate board coordination provided the stability and professional validation that sophisticated patients required for premium healthcare partnerships, but that medical excellence existed only because of the board coordination and administrative management that I had been providing without his knowledge or appreciation. The April 22nd eye appointment where I had been told to find your own ride home because I have important pharmaceutical meetings represented the most devastating miscalculation of Marcus's life about the relationship between family respect and medical administration, between elderly wisdom and modern healthcare expertise, and between the modest grandmother he wanted to dismiss during routine medical care and the administrative authority, whose medical coordination could either continue supporting his comfortable practice or classify his clinic assets as under patient review requiring comprehensive family evaluation and character assessment. The Thornfield Institute for Medical Excellence that had established my reputation throughout the New England healthcare community operated from the modest Brookline apartment office that Marcus considered evidence of my limited professional achievement and outdated lifestyle choices. The federal consultation contracts that generated over $280 annually in administrative service fees were coordinated from the same workspace where I had been developing medical innovations and training healthcare professionals for nearly 5 decades. The retirement that my family assumed represented the end of my professional influence actually marked the beginning of my most lucrative and influential period as an independent consultant, whose expertise was sought by federal health agencies, international medical research networks, and healthcare firms throughout North America who needed guidance on research integration, compliance implementation, and system coordination that served thousands of families and billions of dollars in annual medical transactions. But what made the timing of Marcus's find your own ride home comment particularly unfortunate was that my transition from Boston Medical Research Institute employee to independent consultant had actually increased my authority and access to medical databases throughout the northeastern United States. The consultation contracts that I had negotiated included continued access to all research systems that I had managed during my career, emergency response authority for system failures and compliance incidents, and strategic planning responsibilities for next-generation medical technology that would determine how vision care was managed and coordinated for the next 20 years. The modest Brookline apartment where I had been quietly building my medical empire and maintaining my federal consultation business would soon become the command center for the most comprehensive demonstration of healthcare authority that New England had ever witnessed. The research access that Marcus had never understood or appreciated would become the foundation for consequences that he could never have imagined or prepared for when he decided that his elderly mother should find your own ride home during his carefully prioritized pharmaceutical networking and professional advancement activities. Sometimes the most dangerous assumption you can make about elderly relatives is that their modest lifestyle reflects limited capability rather than understanding that true medical expertise and administrative authority operate most effectively when they remain invisible until the moment when visibility becomes necessary to teach ungrateful family members about the critical importance of respecting the elderly wisdom and administrative knowledge that created the foundation for every healthcare advantage and opportunity. They considered evidence of individual achievement and personal success in competitive medical markets that required both professional competence and family loyalty to navigate successfully. What my family never understood during all those years of treating me like a simple retiree who needed assistance with modern medical technology and ophthalmology terminology was that their comfortable assumption about my limited capabilities revealed their complete ignorance of the medical empire I had built throughout the New England healthcare community, an empire that operated so seamlessly and efficiently that its very invisibility had become its greatest strength and my family's most dangerous vulnerability when they decided that elderly medical needs should be subordinated to professional networking advancement and business optimization. The modest two-bedroom apartment in Brookline where I had lived for 12 years since my husband's passing, which Marcus considered evidence of my limited financial success and outdated lifestyle choices, actually served as the primary coordination center for the New England Regional Medical Research Network, equipped with secured communication systems, encrypted internet connections, and healthcare infrastructure that maintained 24/7 connectivity with vision care facilities throughout -1 northeastern states and enabled immediate response to medical emergencies that could affect millions of dollars in research funding and healthcare coordination activities throughout the most prestigious medical institutions in North America. My home office, which appeared to casual visitors as a simple retirement workspace with basic computer equipment and traditional furniture, contained sophisticated database systems and medical industry hardware that provided direct access to the primary servers at Boston Medical Research Institute, backup communication protocols for emergency healthcare coordination, and secure connections to federal medical databases that required the highest levels of security, clearance, and professional authentication to access and maintain throughout the vision care research community across multiple states and international medical networks. The technology setup that I had installed throughout my apartment represented over $320,000 in specialized equipment and software licensing that enabled me to coordinate research allocation activities, respond to medical emergencies, and maintain the healthcare infrastructure that supported dozens of New England's most exclusive vision centers throughout Massachusetts, Connecticut, Rhode Island, New Hampshire, Vermont, and Maine. The multiple high-resolution monitors that lined my office walls displayed real-time status information from medical databases across 6 states. Automated alert systems that notified me of compliance errors or funding issues requiring immediate attention, and coordination interfaces that allowed me to communicate with healthcare professionals, federal compliance officials, and medical administrators throughout the New England region and beyond. The communication array that dominated the eastern wall of my office included encrypted satellite uplinks that connected directly to the Department of Health and Human Services secure network, quantum encrypted fiber optic connections that provided millisecond response times to medical emergency databases, and classified communication protocols that enabled immediate coordination with federal health officials during crisis situations that could affect national medical research priorities and patient safety standards. The backup power systems that I had installed included military-grade uninterruptible power supplies, diesel generators capable of maintaining full operational capacity for 72 hours during extended power outages, and cellular communication towers that ensured continued connectivity even during natural disasters or infrastructure failures that could compromise standard medical communication networks. But beyond the physical infrastructure that supported my medical coordination responsibilities, what made my home-based operations particularly powerful was the comprehensive network of professional relationships and federal coordination protocols that I had developed throughout my 43-year career in vision care research and medical administration. The daily phone calls that my family occasionally overheard weren't social conversations with retired colleagues, they were strategic consultations with federal health administrators, crisis coordination with state medical officials, and technical support for vision care facilities that processed millions of dollars in daily research transactions throughout the northeastern United States, and coordinated with international medical research networks. The morning coordination calls that began each day at 5:30 a.m. included direct communication with the Centers for Disease Control and Prevention's Vision Health Initiative, strategic planning sessions with the National Eye Institute's Research Allocation Committee, compliance monitoring with state medical boards throughout New England, and emergency response coordination with federal health officials who relied on accurate regional data for national policy development and medical resource allocation. These conversations often involved classified medical information, patient privacy protocols, and research coordination that required security clearances that most medical professionals could never obtain or maintain throughout their entire careers. The afternoon consultation activities included providing technical guidance for medical equipment manufacturers seeking federal approval for experimental vision care devices, coordinating with international medical research organizations implementing our protocols for healthcare management systems in European Union countries, and conducting strategic planning sessions with federal health officials who needed expertise in vision care policy development and medical research coordination. The evening coordination work included emergency response protocols during medical equipment failures or cybersecurity incidents that could affect patient safety, and research integrity throughout multiple states and international medical research partnerships. The Thornfield Institute for Advanced Medical Research, which I had established during the final years of my career at Boston Medical Research Institute, had become the most respected healthcare coordination training program in the Northeastern United States, providing advanced education for medical coordinators, federal compliance officials, and vision care professionals who needed expertise in multi-state research integration, medical protocol implementation, and crisis response coordination that maintain healthcare stability during funding emergencies and research complications that could affect entire regional medical markets, and patient safety standards. Our institute accepted only 8 participants annually through an application process more competitive than federal medical positions, requiring extensive experience in medical research, healthcare coordination, or vision care management before candidates qualified for consideration. The program fee of $420 reflected both the specialized nature of our training and the career advancement opportunities that graduation provided for medical professionals seeking leadership positions in federal health agencies, state medical administration, or vision care organizations throughout New England and the broader medical research community. The waiting list for admission to the Thornfield Institute extended over 7 years, with applications from senior administrative professionals at major medical research facilities, federal health officials seeking advanced health care management training, and state administrators responsible for medical coordination and research oversight throughout multiple northeastern states. We regularly declined applications from Fortune 500 pharmaceutical executives who lacked the specialized knowledge of medical systems and federal health regulations that distinguished our program from general medical education and basic health care management training available through traditional professional programs. What made our program unique wasn't just the medical training quality, it was the federal coordination experience and professional networking opportunities that came with graduation from the most respected medical education program in Northeastern vision care research. Thornfield Institute graduates received automatic consideration for federal health positions that never advertised openings, gained access to our network of medical professionals and federal health officials, and could leverage our consultation services to build careers in medical coordination that would be impossible to achieve through traditional medical education and standard healthcare advancement opportunities. The advanced curriculum that we provided included hands-on training in federal research integration protocols, emergency response coordination during medical crises, multi-state funding coordination, vision care database management, and compliance. Implementation that protected patient privacy while maintaining research access and federal medical monitoring capabilities. Our graduates managed medical databases for federal health agencies, coordinated vision care operations for major metropolitan areas, and supervised research operations for healthcare networks that handled billions of dollars in annual medical transactions and international research coordination. But perhaps the most significant aspect of the Thornfield Institute was our role in developing and implementing the next generation of medical coordination protocols that would determine how vision care research was managed, secured, and coordinated between private healthcare facilities and federal medical databases. The graduates from our program were leading medical innovation at organizations like the National Eye Institute, Centers for Disease Control and Prevention, and Department of Health and Human Services, implementing compliance protocols for federal health agencies, and coordinating research management for state medical systems throughout the northeastern United States. The professional relationships that had developed through our institute included direct connections with senior executives at every major medical research facility, federal health officials responsible for national vision care coordination, and administrative professionals who managed medical systems for state governments, county health departments, and municipal healthcare development departments throughout New England and the broader Northeastern states. These relationships represented decades of professional collaboration and mutual respect that created opportunities for strategic coordination and immediate response capabilities that most medical professionals could never access or afford. My daily routine, which my family observed during their infrequent visits and considered evidence of simple retirement activities and limited social engagement, actually included coordinating medical operations that affected over 4.8 million patient records, supervising emergency response protocols for research failures that could disrupt vision care access throughout multiple states, and providing administrative consultation for federal health officials who relied on accurate Northeastern regional data for national policy analysis and medical resource development. The morning schedule that began each day at 5:15 a.m. included reviewing overnight system alerts from medical databases across 6 northeastern states, analyzing automated error reports that identified potential compliance issues or research integrity problems requiring immediate attention, coordinating with federal health databases that synchronized with our regional systems during off-peak hours, and implementing system updates that maintain compliance protocols and improve database performance for millions of patient records and medical research transactions. The 6:30 a.m. coordination session included direct communication with the Department of Health and Human Services Emergency Response Division, providing real-time medical data analysis for federal policy decisions, coordinating with international medical research organizations that implemented our protocols for healthcare management in 12 different countries, and conducting strategic planning with federal health officials who relied on our expertise for national database modernization and compliance enhancement initiatives. The 8 a.m. research coordination activities included supervising funding integration between county health departments and vision care research facilities, troubleshooting system errors that affected research allocation visibility and patient application processing, coordinating with federal medical officials who needed accurate regional data for policy analysis and healthcare development, and managing crisis response protocols during natural disasters that required immediate coordination between multiple state agencies and private medical organizations. The 10:30 a.m. consultation calls included providing administrative guidance for medical professionals who encountered research errors or system integration problems, coordinating with international vision care networks that implemented our protocols for healthcare management systems in other countries, and conducting strategic planning with federal health officials who relied on our expertise for national database modernization and compliance cement initiatives that affected millions of patients and billions of dollars in annual medical research funding. The afternoon coordination session from 2 p.m. to 4:30 p.m. included emergency response coordination for medical equipment failures or cybersecurity incidents that could affect patient safety. Throughout multiple states, providing technical support for federal health agencies implementing new research coordination protocols, and conducting training sessions for medical professionals who needed advanced expertise in healthcare database management and patient privacy protection requirements. The evening consultation work from 6 p.m. to 8:30 p.m. included providing administrative guidance for medical professionals who encountered complex research coordination problems, coordinating with international medical research networks that implemented our protocols for healthcare management systems in European Union countries, Canada, Mexico, and Pacific Rim nations, and conducting strategic planning with federal health officials who relied on our expertise for next-generation medical technology implementation and healthcare coordination enhancement. But beyond the administrative coordination responsibilities that occupied most of my daily schedule, what made my medical expertise particularly valuable was my comprehensive understanding of how healthcare systems affected individual families and communities throughout the northeastern United States. Every family that received timely medical research approvals, every vision care facility that operated efficiently, every medical treatment that reached appropriate completion, and every emergency response that coordinated effectively represented the successful implementation of systems and protocols that I had spent decades developing, refining, and maintaining. The Boston Medical Research Institute organization where I had spent my entire career wasn't just a regional medical facility, it was the exclusive provider of coordination services for the Federal Health Administration's New England Regional Integration Network, coordinating vision care research for over 1,840 municipal healthcare jurisdictions, 78 major metropolitan medical areas, and managing research integration with 423 different county health departments across 6 northeastern states. Our systems processed over $6.7 billion in annual medical research transactions, coordinated equipment distribution for over 1,200 different hospitals and medical organizations, and maintained the infrastructure that enabled platforms like federal research databases, local vision centers, and medical equipment manufacturers to provide effective healthcare management and patient coordination for thousands of northeastern families. The scope of our research management operations required coordination with the Internal Revenue Service for medical tax compliance and audit support, the Department of Health and Human Services for federal healthcare program integration, the Food and Drug Administration for medical equipment verification, the Environmental Protection Agency for healthcare facility coordination integration, and the Department of Homeland Security for medical allocation verification and security monitoring. That supported both individual privacy protection and national security requirements. My security clearance level required annual background investigations, financial audits, psychological evaluations, and professional competency assessments that ensured only the most qualified and trustworthy medical professionals maintained access to systems that could affect national healthcare programs, regional family medical care, and federal health policy development. The clearance process included polygraph examinations, extensive interviews with professional colleagues and federal officials, and continuous monitoring that verified my continued reliability and commitment to maintaining the highest standards of professional integrity and system security. The administrative innovations that I had developed during my career included automated integration protocols that synchronized patient data between county health databases and federal medical systems, compliance algorithms that protected patient privacy while maintaining research accessibility, error detection systems that identified research irregularities before they affected family healthcare access, and crisis response protocols that maintained system stability during equipment failures. or cybersecurity incidents that could affect millions of patient records and billions of dollars in medical research activity. These innovations had been adopted by medical facilities throughout North America, implemented by federal health agencies for national database modernization, and licensed to international medical firms that wanted to implement similar integration systems and compliance protocols for healthcare management in European Union countries, Canada, Mexico, and Pacific Rim nations seeking to modernize their medical systems and improve research coordination and between government agencies and private medical organizations. The consulting contracts that I had negotiated with federal health agencies included ongoing administrative support for database modernization projects, emergency response coordination during system failures that affected multiple states, compliance, assessment and enhancement for federal medical databases, and strategic planning for next-generation medical technology that would improve system integration and reduce healthcare management costs while maintaining accuracy and security standards that protected both individual patient privacy and federal medical monitoring capabilities. But perhaps the most significant aspect of my medical administration authority was my role in determining which research projects received priority processing and all funding visibility throughout the New England Regional Medical Network. The integration protocols that I had designed included automated quality assessment algorithms that evaluated medical research for appropriateness and completeness, determined funding positioning based on patient need and verification status, and implemented enhanced allocation protocols for research that met the highest standards for medical impact and patient benefit. This meant that research projects associated with my family members had always received the most favorable medical treatment possible priority processing for funding coordination. NHANCD research visibility that attracted maximum federal support, expedited grant application coordination that reduced approval timeframes, and automated compliance verification that prevented administrative problems from affecting their research access or medical status. The seamless healthcare experiences that Marcus had always enjoyed weren't natural consequences of practicing in affluent Massachusetts communities or working with premium medical organizations. They were the direct result of medical preferences and administrative advantages that I had been providing through my coordination authority and system access. Marcus's comfortable practice at his $1.2 million Springfield Vision Therapy Center had benefited from perfect medical services coordination, seamless research funding processing, and enhanced allocation management that attracted maximum federal support because I had personally implemented research protocols that ensured optimal visibility and compliance accuracy. The smooth inspection approval processes that had helped them during their clinic expansion phase 5 years ago had benefited from expedited verification and automated compliance checking that reduced approval timeframes and prevented common administrative delays that affected most medical applications. The comprehensive healthcare services that enabled Marcus's comfortable practice reflected research coordination that I had maintained between county health systems and state medical databases, preventing the service gaps and administrative complications that could have significantly affected his access to federal research funding and medical equipment programs. The excellent medical board relationships that supported his practice development, the research programs that provided revenue growth, and the healthcare infrastructure that supported his professional reputation all depended on medical coordination and board management that required exactly the kind of administrative expertise and federal coordination that I had been providing throughout my entire career. Marcus's career advancement at Springfield Vision Therapy Center had been enhanced by the perfect healthcare infrastructure and research coordination that I had maintained throughout New England's medical network, ensuring that his professional development was supported by seamless federal backing and funding facilities that provided the medical stability necessary for practice expansion and professional reputation maintenance. The flawless administrative experiences that had enabled his practice success reflected database management and coordination protocols that required exactly the expertise I had been developing for over 4 decades. Marcus's success with his vision therapy innovations and his ability to pursue sophisticated treatment research despite substantial equipment investment risks had been supported by the comprehensive federal backing and medical coordination that I had been managing through Massachusetts healthcare infrastructure. The emergency funding facilities that had helped him secure his experimental equipment worth over $400,000. The research programs that supported his continuing education and professional development, and the medical services that maintained his professional image all depended on healthcare coordination and board management that I had been providing without his knowledge or appreciation. But the most ironic aspect of Marcus's comfortable assumptions about my limited medical capabilities was that his own success in innovative vision therapy relied on medical management principles and healthcare coordination techniques that I had pioneered in ophthalmology administration and had been teaching to medical planning professionals for over 2 decades. The seamless patient experiences that he provided to his clients used coordination protocols and research integration design principles that I had developed for medical facilities and had shared through professional conferences and administrative training programs throughout New England. The sophisticated practice that Marcus had achieved through his medical expertise and business development was entirely dependent on the kind of healthcare infrastructure and medical board coordination that I had been developing and maintaining throughout the vision care industry. His beautiful clinic served as his primary professional address because its perfect medical services and accurate board coordination provided the stability and professional validation that sophisticated patients required for premium healthcare partnerships, but that medical excellence existed only because of the board coordination and administrative management that I had been providing without his knowledge or appreciation. The April 22nd eye appointment where I had been told to find your own ride home because I have important pharmaceutical meetings represented the most devastating miscalculation of Marcus's life about the relationship between family respect and medical administration, between elderly wisdom and modern healthcare expertise, and between the modest grandmother he wanted to dismiss during routine medical care and the administrative authority whose medical coordination could either continue supporting his comfortable practice or classify his clinic assets as under patient review requiring comprehensive family evaluation and character assessment. The Thornfield Institute for Advanced Medical Research that had established my reputation throughout the New England medical community operated from the modest Brookline apartment office that Marcus considered evidence of my limited professional achievement and outdated lifestyle choices. The federal consultation contracts that generated over $380 annually in administrative service fees were coordinated from the same workspace where I had been developing medical innovations and training healthcare professionals for nearly 5 decades. The retirement that my family assumed represented the end of my professional influence actually marked the beginning of my most lucrative and influential period as an independent consultant, whose expertise was sought by federal health agencies, international medical research networks, and healthcare firms throughout North America who needed guidance on research integration, compliance implementation, and system coordination that served thousands of families and billions of dollars in annual medical transactions. But what made the timing of Marcus's find your own ride home comment particularly unfortunate was that my transition from Boston Medical Research Institute employee to independent consultant had actually increased my authority and access to medical databases throughout the northeastern United States. The consultation contracts that I had negotiated included continued access to all research systems that I had managed during my career, emergency response authority for system failures and compliance incidents, and strategic planning responsibilities for next-generation medical technology that would determine how vision care was managed and coordinated for the next 20 years. The modest Brookline apartment where I had been quietly building my medical empire and maintaining my federal consultation business would soon become the command center for the most comprehensive demonstration of healthcare authority that New England had ever witnessed. The research access that Marcus had never understood or appreciated would become the foundation for consequences that he could never have imagined or prepared for when he decided that his elderly mother should find your own ride home during his carefully prioritized pharmaceutical networking and professional advancement activities. Sometimes the most dangerous assumption you can make about elderly relatives is that their modest lifestyle reflects limited capability rather than understanding that true medical expertise and administrative authority operate most effectively when they remain invisible until the moment when visibility becomes necessary to teach ungrateful family members about the critical importance of respecting the elderly wisdom and administrative knowledge that created the foundation for every healthcare advantage and opportunity they considered. Evidence of individual achievement and personal success in competitive medical markets that required both professional competence and family loyalty to navigate successfully. Dr. Marcus James Thornfield had built what appeared to be the perfect medical entrepreneur lifestyle in Springfield, Massachusetts, complete with revolutionary vision therapy innovations that had attracted $3.2 million in federal research funding, prestigious partnerships with major medical institutions that provided exclusive treatment, referrals, and professional recognition that distinguished his practice from ordinary optometry offices throughout New England. His transformation from junior optometry resident 7 years ago to chief executive officer of Springfield Vision Therapy Center represented exactly the kind of medical innovation success that healthcare investors respected and celebrated, creating the foundation for the exclusive professional positioning that he had worked systematically to achieve through careful practice development and strategic relationship management. The $1.8 million medical complex that housed Springfield Vision Therapy Center reflected Marcus's understanding of how advanced healthcare facilities needed to demonstrate sophistication through cutting-edge design and premium medical technology infrastructure. The 12,000-square-foot facility featured floor-to-ceiling windows overlooking the Connecticut River, state-of-the-art research laboratories with equipment worth over $650,000. Specialized treatment rooms designed for complex vision rehabilitation programs, and presentation areas that could accommodate sophisticated investor meetings and medical conference demonstrations that required elegant presentation and flawless coordination. But what made Marcus's professional success particularly impressive was his systematic approach to building the kind of vision care medical practice that attracted federal research partnerships, while establishing his reputation as Massachusetts' premier innovator for complex vision disorders and advanced therapeutic protocols. The business strategy that he had developed over the past 6 years included comprehensive federal compliance coordination, cutting-edge research implementation, and medical networking that created opportunities for professional advancement while maintaining the sophisticated image that distinguished successful medical entrepreneurs from those who compromised clinical excellence for short-term financial gain. The medical equipment collection that distinguished Marcus's practice represented over $850 in advanced diagnostic and treatment technology that served as a visible demonstration of his commitment to medical innovation and patient care excellence. The centerpiece of his research laboratory was a $180,000 advanced retinal imaging system manufactured by Heidelberg Engineering, featuring swept-source optical coherence tomography capabilities, automated image analysis algorithms, and research-grade data collection protocols that attracted attention from ophthalmology researchers and medical device manufacturers throughout the northeastern United States. The clinical treatment areas included a $95,000 vision therapy rehabilitation suite equipped with computerized eye tracking systems, virtual reality treatment protocols, and biofeedback monitoring technology that provided comprehensive assessment and treatment capabilities for complex vision disorders including amblyopia, strabismus, convergence insufficiency, and traumatic brain injury-related vision problems. The rehabilitation equipment had been acquired through federal research grants that Marcus had described as surprisingly smooth and incredibly favorable, with approval processes that required minimal documentation, funding rates that exceeded STANDARD research allocations, and equipment coordination that provided white glove installation and training services. Marcus's $65,000 Pediatric Vision Assessment Center featured child-friendly diagnostic equipment, specialized testing protocols for developmental vision disorders, and family consultation areas designed to provide comprehensive care for children with learning-related vision problems. The pediatric facility had attracted partnerships with Springfield Public Schools, Western Massachusetts Regional Education Cooperative, and 3 major pediatric hospitals that referred complex cases requiring advanced vision therapy intervention and specialized treatment coordination. The research coordination office that Marcus had established within his practice included $45,000 in database management systems, federal compliance monitoring software, and clinical trial coordination technology that enabled his participation in multi-center research studies investigating innovative treatment protocols for vision disorders. The research capabilities had attracted collaboration opportunities with Harvard Medical School's Department of Ophthalmology, Boston University's Center for Vision Research, and the Massachusetts Eye and Ear Infirmary's Pediatric Vision Laboratory. Marcus's professional success at Springfield Vision Therapy Center had been built around his expertise in developing treatment protocols that appealed to patients seeking comprehensive vision care while demonstrating measurable clinical outcomes that satisfied insurance companies and federal research agencies. His patient portfolio included complex cases referred from neurologists throughout Western Massachusetts, pediatricians seeking specialized vision therapy for children with learning disabilities, and rehabilitation specialists who needed advanced vision treatment for traumatic brain injury patients. The treatment innovation that had established Marcus's reputation throughout the medical community was his integrated neuroplasticity vision rehabilitation protocol, which combined traditional vision therapy techniques with cutting-edge neurofeedback technology and virtual reality training systems. The protocol had been featured in peer-reviewed medical journals, presented at international vision therapy conferences in Montreal, London, and Sydney, and adopted by over 60 vision centers throughout North America seeking to implement similar treatment methodologies for complex vision disorders. Marcus's approach to vision therapy reflected his understanding that patients with complex vision problems demanded evidence-based treatment protocols rather than traditional eye exercises, requiring medical professionals who could demonstrate measurable clinical outcomes and coordinate with other healthcare providers throughout the patient's treatment journey. His clinical presentations included detailed neurological assessment, comprehensive vision system analysis, and strategic treatment recommendations that help patients achieve functional vision improvements, while addressing underlying neurological factors affecting visual performance. The professional relationships that Marcus had developed throughout his medical career included direct connections with neurologists at Bay State Medical Center, pediatric specialists at Boston Children's Hospital, rehabilitation coordinators at Massachusetts General Hospital's Brain Injury Program, and research investigators who collaborated on federal studies investigating vision therapy effectiveness for various neurological conditions. These relationships represented years of professional networking and clinical collaboration that created opportunities for patient referrals and research participation that most vision therapy practitioners could never access or develop. The clinical research projects that Marcus had initiated at Springfield Vision Therapy Center included participation in a $2.1 million National Eye Institute study investigating vision therapy effectiveness for amblyopia treatment, collaboration with the Department of Defense on $890,000 research grant studying vision rehabilitation for military personnel with traumatic brain injuries, and coordination with the National Institutes of Health on a $1.4 million multi-center trial examining computerized vision therapy protocols for children with learning disabilities. Marcus's research methodology reflected sophisticated understanding of clinical trial protocols, federal compliance requirements, and statistical analysis techniques that distinguished his work from standard vision therapy practice and positioned his clinic as a premier research facility capable of contributing to evidence-based vision care advancement. His publications had appeared in the Journal of Behavioral Optometry, Optometry and Vision Science, Current Opinion in Ophthalmology, and Vision Research, establishing his credibility within the academic medical community and attracting additional research collaboration opportunities. The business development strategy that Marcus had implemented at Springfield Vision Therapy Center generated $2.8 million in annual revenue while maintaining profit margins that exceeded industry standards by 280%, creating the kind of financial success that distinguished premier medical practices from standard neighborhood vision care offices. His practice processed over 3,400 patient visits annually, maintained a patient satisfaction rating of 96%, and achieved clinical success rates that exceeded published benchmarks for vision therapy effectiveness by an average of 34%. But what made Marcus's professional achievement particularly remarkable was his development of proprietary diagnostic protocols that had been licensed to medical device manufacturers seeking to implement similar assessment techniques in their equipment design. The licensing agreements generated over $180,000 in annual royalty payments while establishing Marcus as a recognized expert in vision assessment technology and treatment protocol development. Marcus's personal lifestyle reflected his professional success through sophisticated choices that demonstrated his commitment to maintaining the kind of image that distinguished successful medical entrepreneurs from those who compromised personal presentation for business advancement. His primary residence was a stunning $890,000 contemporary home in Springfield's most prestigious neighborhood, featuring 4 bedrooms, 3 bathrooms, a home office designed for medical consultation, and entertaining areas that could accommodate sophisticated professional events and medical networking gatherings. The home's interior design reflected Marcus's appreciation for modern medical aesthetics, with clean lines, premium materials, and technology integration that provided the perfect environment for hosting pharmaceutical representatives, medical device consultants, and research collaboration meetings that supported his continued professional advancement and business development. The kitchen featured professional-grade appliances and a large island that served as an informal conference area for strategic planning sessions and professional relationship development. Marcus's vehicle collection included a $75,000 BMW X5 M50i in Alpine White, featuring a twin-turbo V8 engine, premium leather interior, and advanced technology systems that provided the comfort and professional image necessary for medical conference travel and client relationship management. The BMW had been acquired through a financing arrangement that Marcus described as mysteriously favorable, with approval processes that bypassed standard credit evaluation, interest rates that were substantially below market standards, and dealer coordination that provided concierge-level service throughout the entire purchase experience. His secondary vehicle was a $45,000 Audi A4 Allroad in Quantum Gray, serving as daily transportation while maintaining the sophisticated image that his patients and professional colleagues expected from a successful medical entrepreneur. The Audi purchase had been coordinated through dealer relationships that provided exclusive access to limited availability options and financing terms that Marcus's medical colleagues described as impossibly advantageous for someone without established dealer connections. The recreational activities that Marcus pursued reflected his commitment to maintaining the sophisticated lifestyle that successful medical professionals needed to demonstrate their expertise and financial success. His memberships included the exclusive Springfield Country Club, where annual dues exceeded $15 and provided networking opportunities with the region's most successful business leaders and medical professionals, and the prestigious Massachusetts Medical Society Research Committee, which required extensive peer review and professional recommendations for membership consideration. Marcus's vacation preferences included luxury medical conferences in destinations like Aspen, Napa Valley, and Martha's Vineyard, where he could combine continuing education requirements with professional networking opportunities that supported his research, collaboration, development, and business advancement. These conferences typically cost between $8,000 and $12,000, including travel, accommodation, and registration fees, representing substantial investment in professional development that distinguished serious medical entrepreneurs from those who prioritized short-term cost savings over career advancement. The wardrobe that Marcus maintained for professional presentations included custom-tailored suits from Brooks Brothers, premium leather shoes from Allen Edmonds, and luxury accessories that demonstrated his attention to detail and commitment to professional excellence. His medical conference presentations required sophisticated visual materials, premium technology equipment, and presentation coordination that could cost between $5,000 and $8,000 per conference, reflecting his understanding that successful medical professionals needed to invest substantially in their professional image and presentation quality. Marcus's continuing education activities included enrollment in executive medical management programs at Harvard Business School, advanced clinical research methodology courses at Boston University, and specialized vision therapy certification programs that required extensive travel and substantial financial investment. The total annual cost of his professional development activities exceeded $35,000. Representing his commitment to maintaining the cutting-edge expertise that distinguished premier medical practices from standard healthcare providers. The dining and entertainment preferences that Marcus maintained reflected his sophisticated tastes and professional networking requirements. His regular restaurants included high-end establishments like Ms. Bistro Plus Bar, Student Prince Cafe, and the Red Rose Pizzeria, where he could host pharmaceutical representatives, medical device consultants, and research collaboration partners in environments that demonstrated his success and commitment to relationship development. But perhaps most importantly, Marcus's professional success had enabled him to establish the Marcus J. Thornfield Foundation for Vision Research, a nonprofit organization that provided research grants to young investigators studying innovative vision therapy techniques and advanced diagnostic protocols. The foundation had awarded over $240,000 in research grants during its 3 years of operation, establishing Marcus's reputation as a leader in vision care philanthropy and medical research advancement. The foundation's annual gala, held each November at the prestigious Springfield Museums, attracted medical professionals, pharmaceutical executives, and healthcare technology leaders from throughout New England who wanted to support vision research advancement while networking with the region's most influential medical entrepreneurs. The event typically raised between $180,000 and $220,000 annually, with proceeds supporting research grants and educational programs that advanced vision care knowledge and treatment effectiveness. Marcus's speaking engagements included presentations at medical conferences throughout North America, with honorariums ranging from $5,000 to $15,000 per presentation depending on the conference prestige and audience size. His most requested presentation, integrating technology and traditional therapy, the future of vision rehabilitation, had been delivered at over 30 medical conferences during the past 2 years, establishing his reputation as a premier expert in advanced vision therapy methodology. The consulting work that Marcus provided to medical device manufacturers included protocol development for new diagnostic equipment, clinical trial design for vision therapy technology, and regulatory compliance guidance for companies seeking FDA approval for innovative vision care devices. These consulting relationships generated between $45,000 and $80,000 annually while providing opportunities for early access to cutting-edge medical technology and research collaboration partnerships. Marcus's media appearances included interviews on regional medical television programs, quotes in healthcare industry publications, and feature articles in medical journals highlighting his innovative approach to vision therapy and advanced diagnostic protocols. The media attention had enhanced his professional reputation while attracting patient referrals from throughout New England and creating opportunities for additional research collaboration. ND Business Development. The investment portfolio that Marcus had developed through his medical practice success included real estate holdings, medical technology stocks, and pharmaceutical company investments that provided diversified income streams and long-term financial security. His financial advisor had recommended aggressive growth strategies that could support early retirement and expanded philanthropic activities. Reflecting the substantial wealth accumulation that his medical practice had generated during its rapid expansion phase, the lifestyle that Marcus had achieved through his medical expertise and business development required careful coordination and substantial financial investment to maintain the sophisticated image that successful medical entrepreneurs needed. To demonstrate their expertise and professional credibility, the seamless coordination of his practice operations, research activities, professional development, and personal lifestyle reflected years of strategic planning and systematic investment in the relationships and resources that distinguished premier medical practices from standard healthcare providers. But what made Marcus's comfortable lifestyle particularly ironic was his systematic assumption that his medical success represented independent achievement, rather than understanding that every aspect of his professional advancement had been supported by healthcare infrastructure and medical coordination that required exactly the kind of administrative expertise and federal relationships that I had been developing throughout my career in medical research and ophthalmology administration. The perfect research grant approvals that had enabled his equipment acquisitions, the seamless inspection processes that supported his practice expansion, the favorable financing arrangements that facilitated his lifestyle maintenance, and the federal research partnerships that established his professional credibility all depended on medical coordination and administrative management that operated invisibly behind the scenes to ensure his continued success and professional advancement. The confidence that Marcus displayed about his medical achievements and professional recognition reflected his complete ignorance of the healthcare administration infrastructure that had been ensuring his seamless practice operations, optimal research funding, and comprehensive regulatory compliance throughout his entire career. The comfortable assumptions that he maintained about automatic medical success would soon be challenged by the reality that true healthcare excellence required respecting the administrative expertise and professional relationships that created opportunities for authentic medical advancement rather than taking for granted the coordination and support that made his sophisticated practice possible. The April 22 decision to abandon his elderly mother at a routine eye appointment while pursuing pharmaceutical networking opportunities would reveal the character priorities that distinguished Marcus's understanding of professional success from traditional family values and elderly respect requirements. The systematic dismissal of family medical needs in favor of business advancement would become the documented foundation for consequences that demonstrated the true relationship between family loyalty and medical privilege, between elderly wisdom and healthcare authority, and between the successful optometrist who considered his mother a transportation inconvenience and the medical research coordinator whose expertise had created every advantage he considered evidence of individual achievement and personal success. The systematic dismissal that I had experienced from Marcus throughout the years wasn't a recent development, it was the culmination of a carefully constructed pattern of elderly devaluation and family relationship management that had been evolving for over 8 years. Beginning shortly after his graduation from the New England College of Optometry, when his initial modest success started transforming into the kind of professional confidence that distinguished ambitious medical entrepreneurs from those who maintain traditional respect for elderly wisdom and family contribution. The comfortable assumptions that Marcus had developed about my limited understanding of modern healthcare reflected months of strategic thinking about family obligation optimization and his systematic calculation that elderly relatives represented potential obstacles to professional advancement rather than valuable resources deserving continued respect and inclusion. The transformation in Marcus's attitude toward family relationships had become particularly apparent during the summer of 2019, when his vision therapy practice began attracting federal research funding and prestigious medical partnerships that convinced him his success represented individual achievement rather than coordinated support from healthcare infrastructure that required exactly the kind of administrative expertise I had been providing throughout my career. The confident dismissal that he began expressing toward my medical opinions, healthcare knowledge, and professional experience reflected his growing belief that modern medical education and contemporary technology had rendered elderly expertise obsolete and irrelevant to current healthcare practice. The first significant incident that revealed Marcus's systematic approach to family relationship management occurred during Thanksgiving dinner in 2019. When I offered to review his federal research grant application for a $340,000 National Eye Institute study investigating vision therapy effectiveness for pediatric amblyopia treatment, my suggestion that certain compliance protocols might require additional documentation and federal coordination was met with condescending explanation about how modern grant application systems are completely automated and don't require the kind of manual oversight that might have been necessary during your generation of medical research. The dismissive tone that Marcus employed during that conversation revealed his comfortable assumption that elderly medical professionals lacked understanding of contemporary research methodology and federal compliance requirements that distinguished current healthcare practice from outdated approaches to medical administration. His confident explanation that everything is digital now, Mom, and the approval processes are streamlined through artificial intelligence systems that eliminate the bureaucratic complications you might remember from old-fashioned medical research, demonstrated his complete ignorance of the sophisticated coordination and administrative expertise that had been ensuring his seamless research experiences throughout his entire career. The pattern of systematic dismissal continued expanding throughout 2020 and 2021. When Marcus's practice success generated the kind of financial confidence that convinced him his healthcare achievement represented superior understanding of medical business management and patient care coordination. The comfortable assumptions that he maintained about my limited capabilities became particularly apparent during family gatherings where he would explain modern medical concepts with the kind of patronizing language typically reserved for individuals who lacked basic healthcare knowledge or professional medical experience. During Christmas dinner in 2020, Marcus spent 45 minutes explaining the revolutionary nature of electronic medical records and digital patient coordination systems, describing these innovations as if they represented breakthrough technology. Rather than understanding that I had been personally involved in developing the federal protocols and administrative frameworks that enabled these systems to function effectively throughout the New England healthcare network, his confident lecture about how modern medical practices use sophisticated database management to coordinate patient care across multiple providers revealed his complete ignorance that the database integration protocols he was describing had been designed and implemented through exactly the kind of administrative expertise I had been developing for decades. The most revealing aspect of Marcus's educational presentations during family gatherings was his systematic assumption that elderly relatives needed basic explanation of medical concepts and healthcare terminology rather than recognizing that traditional medical education and decades of professional experience might provide perspectives that complemented rather than competed with contemporary healthcare innovation. His comfortable confidence in explaining complex medical procedures and advanced diagnostic techniques demonstrated his complete transformation from respectful family member to condescending educator who treated elderly relatives like uninformed students requiring remedial healthcare instruction. The systematic approach that Marcus developed for managing family relationships during professional events became particularly apparent during his foundation gala activities, where my presence was strategically managed to minimize potential complications for his sophisticated medical networking and philanthropic positioning. The careful coordination that he implemented for these events included specific instructions about appropriate conversation topics, dress code requirements that ensured professional image consistency, and strategic positioning that prevented extended interaction between elderly family members and his medical colleagues or pharmaceutical industry partners. During the November 2021 Marcus J. Thornfield Foundation for Vision Research Gala, I was assigned to a table in the back corner of the reception area, positioned away from the main presentation stage and strategically isolated from the networking zones where Marcus conducted his most important professional relationship development activities. The seating arrangement ensured that his medical colleagues and research partners would have minimal opportunity for extended conversation with elderly family members who might compromise his sophisticated professional image or create complications for his business advancement goals. The systematic isolation that I experienced during that gala included explicit instructions about limiting my participation in medical discussions, avoiding detailed conversation about my professional background, and maintaining appropriate elderly relative behavior that supported rather than complicated Marcus's fundraising objectives and professional networking activities. The confident assumptions that Marcus expressed about appropriate family member behavior reflected his complete transformation from traditional family values to business optimization thinking that prioritized professional advancement over elderly inclusion and generational respect. The most devastating example of Marcus's systematic family relationship management occurred during the spring of 2022, when his practice was featured in a regional medical journal article highlighting innovative vision therapy approaches and successful research collaboration with federal agencies. The photographer and journalist who visited Springfield Vision Therapy Center for the feature story were specifically instructed that family members would not be available for interviews or inclusion in the professional presentation, ensuring that the article focused exclusively on Marcus's individual achievements and medical innovations rather than acknowledging any family support or generational contribution to his professional success. When I expressed interest in attending the photography session and potentially contributing perspective about the evolution of vision care research over the past several decades, Marcus's response revealed the depth of his systematic approach to elderly exclusion and professional image management. Mom, this is a sophisticated medical publication that focuses on cutting-edge research and contemporary treatment protocols, he explained with the kind of professional language that treated elderly involvement as potential liability rather than valuable addition to healthcare discussion. The article needs to demonstrate our clinic's position at the forefront of medical innovation, and having elderly family members involved in the presentation might create confusion about our focus on advanced technology and modern research methodologies. Marcus continued with systematic emphasis on image optimization that justified excluding elderly relatives during professional recognition opportunities. The confident calculation that he expressed about family member exclusion reflected months of strategic thinking about professional positioning, and his assumption that elderly presence might compromise his sophisticated medical reputation. The systematic nature of Marcus's family relationship management became even more apparent through his approach to medical appointment coordination and healthcare responsibility sharing, where my routine vision care needs were increasingly treated as logistics problems requiring efficient resolution rather than family obligations deserving personal attention and elderly care consideration. The comfortable assumptions that he maintained about appropriate family member responsibility reflected his transformation from traditional healthcare values to business efficiency thinking that prioritized professional scheduling over elderly accommodation and medical support requirements. The pattern of appointment dismissal that developed throughout 2022 and 2023 included systematic delegation of elderly transportation to rideshare services, medical appointment coordination through automated scheduling systems rather than personal involvement, and healthcare decision support provided through brief phone conversations rather than in-person consultation and family collaboration. The efficient approach that Marcus implemented for managing elderly medical needs reflected his calculation that direct family involvement represented optional convenience, rather than essential obligation during routine healthcare maintenance and preventive care activities. During my routine diabetic eye examination in September 2022, Marcus's response to my request for transportation assistance revealed his systematic approach to elderly ethical care optimization and family obligation management. Mom, I've arranged for an Uber to pick you up and bring you home after your appointment, he announced with businesslike efficiency that treated elderly transportation as logistics problem rather than family responsibility requiring personal attention and care coordination. The automated scheduling will ensure that you have reliable transportation without requiring my involvement in routine medical appointments that don't need family member participation. Marcus continued with professional language that distinguished essential medical emergencies from optional convenience services that elderly relatives should manage independently. The confident assumptions that he expressed about appropriate family member responsibility reflected his complete transformation from traditional elderly care values to efficiency optimization thinking that prioritized professional scheduling over generational respect and family medical support. The most systematic example of Marcus's family relationship optimization occurred during the development of his consultation work with medical device manufacturers, where potential conflicts of interest required careful management to ensure that personal relationships didn't compromise his professional judgment or research integrity. The strategic approach that he implemented included systematic evaluation of family member involvement in any activities that might affect his consulting relationships, research partnerships, or professional credibility within the medical technology industry. When Heidelberg Engineering offered Marcus a consulting contract worth $45,000 annually to provide clinical feedback about their advanced retinal imaging systems, his immediate concern focused on ensuring that family relationships didn't create potential compliance issues or professional complications that might affect his eligibility for the consulting arrangement. The systematic evaluation that he conducted included specific questions about family member employment in healthcare technology, potential conflicts of interest related to medical device investment, and strategic coordination to ensure that elderly relatives understood appropriate boundaries regarding discussion of his consulting work and professional relationships. The detailed instructions that Marcus provided about confidentiality requirements and professional boundary management revealed his assumption that elderly family members might lack understanding of contemporary compliance requirements and federal regulations governing medical device consulting relationships. His systematic explanation of complex regulatory requirements that prevent family members from discussing consulting work or professional relationships outside the immediate family demonstrated his comfortable confidence that elderly relatives needed careful instruction about appropriate behavior and professional boundary maintenance. But perhaps the most revealing aspect of Marcus's systematic family relationship management was his approach to professional networking events and medical conference attendance, where elderly family member involvement was strategically minimized to ensure optimal business development and career advancement opportunities. The careful coordination that he implemented for these activities included specific protocols for managing family relationship information, strategic presentation of personal background that emphasized professional achievement rather than family support, and systematic exclusion of elderly perspectives from professional conversations and business relationship development. During his presentation at the 2023 International Conference on Vision Therapy in Toronto, Marcus's professional biography and speaker introduction included detailed information about his educational background, research achievements, and clinical innovations while completely omitting any reference to family medical background, generational influence on his career development, or elderly wisdom that might have contributed to his professional perspective. and healthcare expertise. The strategic omission reflected his systematic calculation that family acknowledgement might compromise his sophisticated professional image or create complications for his medical networking and business advancement goals. The networking activities that Marcus pursued during medical conferences included careful management of personal information sharing, strategic positioning that emphasized individual achievement and professional competence, and systematic avoidance of conversations that might reveal family medical background or elderly influence on his career development. The professional presentation that he maintained during these events reflected months of strategic thinking about image optimization, and his assumption that family acknowledgement represented potential vulnerability rather than authentic professional strength. The most devastating pattern that emerged from Marcus's systematic family relationship management was his comfortable assumption that elderly medical knowledge and healthcare experience represented outdated information that lacked relevance to contemporary practice rather than recognizing that traditional medical wisdom might provide valuable perspective that complemented modern healthcare innovation. The confident dismissal that he expressed toward generational expertise reflected his complete transformation from respectful family member to patronizing educator who treated elderly relatives like uninformed individuals requiring basic healthcare instruction. The systematic approach that Marcus developed for managing elderly medical opinions included polite dismissal of suggestions about patient care, condescending explanation of modern medical concepts that elderly relatives might not understand, and strategic redirection of conversations away from topics where generational experience might challenge his professional expertise or contemporary healthcare assumptions. The comfortable confidence that he maintained about superior medical knowledge reflected his complete ignorance of the administrative infrastructure and professional coordination that had been enabling his seamless healthcare experiences throughout his entire career. During a family dinner conversation in March 2023, when I mentioned that certain patient coordination protocols might benefit from additional attention to federal compliance requirements and privacy protection standards, Marcus's response revealed the depth of his systematic dismissal of elderly medical expertise. "Mom, you have to understand that modern medical practice operates under completely different regulatory frameworks than what you might remember from traditional healthcare administration," he explained, with patronizing patients that treated elderly concerns as outdated worries rather than legitimate professional observations. The contemporary compliance systems are automated and integrated with federal databases that eliminate the manual oversight and administrative complexity that characterized old-fashioned medical practice. Marcus continued with confident explanation that demonstrated his complete ignorance that the automated systems he was describing depended entirely on the administrative frameworks and coordination protocols that I had been developing and maintaining throughout my career in medical research and healthcare administration. The comfortable assumptions that Marcus maintained about technological superiority and automated efficiency reflected his systematic transformation from traditional family respect to business optimization thinking that prioritized modern innovation over generational wisdom and elderly expertise. The confident dismissal that he expressed toward administrative concerns revealed his complete ignorance of the sophisticated coordination and professional relationships that had been ensuring his seamless medical practice operations and optimal federal compliance throughout his entire career. The pattern of systematic dismissal reached its culmination during the spring of 2024. When Marcus's practice expansion required additional federal research coordination and regulatory compliance that should have benefited from exactly the kind of administrative expertise and healthcare system knowledge that I had been developing for over 4 decades. Instead of recognizing potential family resources and professional consultation opportunities, Marcus's approach reflected his assumption that elderly relatives lacked understanding of contemporary healthcare challenges and modern medical practice requirements. When his application for a $1.2 million National Institutes of Health research grant required extensive documentation and federal coordination protocols, Marcus's systematic exclusion of family consultation and administrative guidance reflected his comfortable confidence that modern medical education and contemporary professional networks provided superior resources compared to traditional expertise and generational knowledge. The strategic independence that he maintained during the application process demonstrated his complete transformation from family collaboration to individual achievement thinking that treated elderly involvement as potential complication rather than valuable resource. The systematic approach that Marcus had developed for family relationship management included careful boundary maintenance between professional activities and elderly involvement, strategic information sharing that minimized family member understanding of his business operations and medical practice coordination, and systematic exclusion of generational perspectives from professional decision-making and healthcare practice development. The confident assumptions that he maintained about appropriate family member roles reflected his complete transformation from traditional values to business optimization thinking that prioritized professional advancement over elderly respect and family collaboration. The April 22 appointment that would change everything represented the logical culmination of Marcus's systematic family relationship management and his comfortable calculation that elderly medical needs should be subordinated to professional networking opportunities and business advancement priorities. The confident decision to abandon elderly transportation responsibility in favor of pharmaceutical industry meetings reflected years of strategic thinking about family obligation optimization, and his assumption that professional success justified excluding elderly relatives from healthcare support and family consideration during routine medical activities. The systematic dismissal that I would experience during that appointment wasn't an isolated incident of family disrespect. It was the predictable result of Marcus's transformation from traditional family values to business efficiency thinking that treated elderly relatives like logistics problems requiring minimal involvement rather than family members deserving personal attention and care coordination. The comfortable assumptions that he maintained about elderly independence and professional priority would become the documented foundation for consequences that revealed the true relationship between family respect and medical privilege, between elderly wisdom and healthcare authority, and between the successful optometrist who considered his mother a transportation inconvenience and the medical research coordinator whose expertise had created every advantage. He considered evidence of individual achievement and personal success. April 22, 2025. Had begun with routine weather conditions and standard medical scheduling that should have created no complications for basic family transportation and elderly healthcare coordination. My scheduled 2:30 p.m. comprehensive eye examination at Springfield Vision Center represented standard preventive care that elderly diabetic patients required every 6 months to monitor for retinal complications and ensure continued vision health through appropriate medical supervision and timely intervention when necessary. The appointment had been coordinated 3 weeks in advance through my insurance provider's automated scheduling system, confirmed twice through electronic reminders, and planned with the understanding that Marcus would provide transportation assistance since the examination included pupil dilation that would temporarily affect my ability to drive safely home after the appointment. This arrangement represented basic family consideration and elderly care responsibility that should have been easily managed through simple schedule coordination rather than complex decision-making or professional compromise. At 11:30 a.m., I called Marcus's office to confirm our transportation arrangement and verify the timing for pickup after my appointment. The conversation that followed would become the triggering incident that revealed years of systematic family dismissal and transformed comfortable assumptions about medical privilege into the most expensive education about elderly respect and healthcare authority that any Massachusetts optometrist had ever received. Marcus, I wanted to confirm that you'll be able to pick me up after my eye appointment this afternoon. I began with the practical tone that elderly relatives use when coordinating routine medical logistics with family members who understand basic care responsibilities. The response that I received revealed Marcus's immediate calculation of business priorities versus family obligations, and his systematic approach to managing elderly relatives during professional activities that required sophisticated coordination and exclusive business networking. Mom, honestly, I have an incredibly important pharmaceutical consultation meeting this afternoon with representatives from Alcon, Johnson & Johnson Vision, and Bash Plus Lom. He replied with obvious emphasis on the financial importance of the business networking opportunity. This meeting could generate over $200,000 in consulting contracts and establish partnerships that would transform my practice's research capabilities. Marcus continued while reviewing his appointment calendar and coordinating with his staff about conference room preparation and presentation materials. These pharmaceutical executives are flying in specifically to discuss collaboration opportunities, and I can't have any scheduling complications that might affect this business development opportunity. The business language that Marcus employed during our conversation revealed months of strategic thinking about family relationship management and professional image optimization that treated elderly relatives as potential obstacles to career advancement rather than family members deserving basic health care support during routine medical appointments. The confident dismissal that he expressed reflected his complete transformation from traditional family values to business optimization thinking that prioritized networking opportunities over elderly welfare and basic care requirements. The problem is that your appointment timing conflicts with the most important business meeting of my career, Marcus explained with systematic emphasis on professional advancement that justified abandoning elderly transportation responsibility during routine healthcare activities. I've invested months in coordinating this pharmaceutical consultation, and the potential contracts could fund equipment upgrades and research expansion that would establish my practice as the premier vision center in Western Massachusetts. The systematic nature of Marcus's response became apparent through his confident assumption that elderly relatives should solve their own transportation problems through independent arrangements rather than expecting family accommodation that might compromise business networking and professional development opportunities. The comfortable delegation of elderly care to alternative solutions reflected character calculations that treated family obligations as obstacles to professional advancement rather than fundamental responsibilities that distinguished caring relatives from those who prioritized business success over human welfare. You're going to need to find alternative transportation for your appointment, Marcus announced with business decision-making language that treated elderly health care as optional convenience rather than essential family responsibility during routine medical care. I've already confirmed this pharmaceutical meeting months ago, and these executives have extremely limited availability for consultation meetings. The professional language that Marcus used to describe elderly transportation alternatives revealed his complete support for excluding family members during business events that required sophisticated presentation and exclusive professional networking. There are several excellent rideshare options available, and your appointment shouldn't take more than 2 hours, including the dilation recovery time. He continued with systematic emphasis on independent problem-solving that justified excluding elderly relatives during crucial professional advancement opportunities. Mom, you have to understand that this pharmaceutical consultation represents years of business development and relationship building, Marcus explained while coordinating with his office staff about catering arrangements and presentation technology setup. The consulting contracts that we're negotiating could provide funding for advanced research equipment and clinical trial participation that would establish my practice's reputation throughout New England. The systematic approach that Marcus described for managing family complications revealed months of strategic consultation about relationship management and business development that treated elderly accommodation as potential interference with professional advancement rather than basic human obligations during routine healthcare situations. The comfortable confidence that he displayed about implementing elderly independence reflected his calm, complete embrace of business thinking that subordinated family welfare to marketing objectives and networking success. The meeting includes presentations by 3 major pharmaceutical companies, equipment demonstrations worth over $300,000, and contract negotiations that could generate substantial ongoing revenue for my practice, Marcus. Continued with systematic emphasis on financial priorities and business advancement that justified abandoning elderly relatives during routine medical appointments requiring family transportation assistance. The conversation that continued revealed Marcus's complete commitment to prioritizing business networking over elderly healthcare needs and his systematic approach to family relationship management that treated my transportation emergency as a logistics problem requiring independent resolution rather than family obligation deserving immediate accommodation and care coordination. The professional language that they used demonstrated months of strategic thinking about elderly relationship optimization and business development that justified dismissing family safety concerns. During crucial professional advancement opportunities, I'm sure you can manage the transportation logistics independently, Marcus announced with confident assumption that elderly relatives should accommodate professional networking through problem-solving, rather than expecting basic family support. During routine healthcare appointments that required post-procedure assistance and safety coordination, the systematic dismissal that I experienced revealed Marcus's complete calculation that elderly relatives should prioritize business advancement over personal healthcare needs, and his comfortable assumption that professional networking opportunities justified excluding family members from basic care coordination during routine medical activities that required transportation assistance and post-procedure support. The moment that Marcus ended our phone call at 11:47 a.m., dismissing my healthcare needs for his pharmaceutical networking event, I walked into my Brookline Command Center and began implementing the most comprehensive demonstration of medical authority that New England had ever witnessed. The healthcare coordination actions that I executed over the following 6 hours would transform Marcus's comfortable assumptions about vision care privilege and federal research funding into the most expensive education about family respect and elderly wisdom that any Massachusetts optometrist had ever received. As I sat surrounded by my $320,000 command center, overlooking multiple monitors displaying real-time data from medical facilities across 6 states, I reflected on the devastating irony of being abandoned during routine health care by the family member whose medical success depended entirely on the federal coordination and administrative authority that I had been providing without his knowledge throughout his entire professional career. At 12:15 p.m., I accessed the New England Regional Medical Research Network through my federal consultation protocols and initiated a comprehensive review of all research funding, federal compliance status, and medical equipment allocations associated with Dr. Marcus James Thornfield and Springfield Vision Center. The security protocols that I implemented required federal-level authentication and triggered automated notification systems that alerted medical facilities throughout the region about potential compliance irregularities requiring immediate evaluation and administrative review. The medical database that displayed Marcus's complete practice history revealed the extensive coordination that I had been providing throughout his vision therapy activities, including expedited research approvals that bypassed standard federal evaluation procedures, medical equipment access that provided exclusive technology worth over $850,000, federal compliance coordination that ensured perfect inspection results, and research allocation that guaranteed funding approval for projects that other practices waited years to receive through standard medical channels. At 1:30 p.m., I implemented the first administrative modification by updating Marcus's practice status classification in the Federal Health Administration Master Database from Preferred Research Coordination to Under Administrative Review for Compliance Evaluation. The classification change triggered immediate notification protocols that informed medical facilities throughout New England about potential service modifications and federal funding review requirements that could affect continued eligibility for research grants and medical equipment access. The systematic nature of the classification modifications ensured that every federal agency, research funding organization, medical equipment manufacturer, and pharmaceutical company connected to Marcus's practice experienced coordinated changes that created immediate complications for his professional operations and long-term consequences for his research funding expectations. The integration protocols that I had designed years earlier activated automated evaluation procedures that could result in funding suspension, equipment reallocation, or complete federal partnership termination based on family conduct assessment and professional priority recalculation. By 2:45 p.m., as I sat comfortably in my apartment office while Marcus presumably entertained his pharmaceutical executives, the first automated notifications had been generated by federal systems detecting compliance irregularities affecting Springfield Vision Therapy Center's research eligibility and funding coordination status. The alert protocols included federal funding notification requirements that triggered immediate evaluation of research grants and equipment allocations that could affect Marcus's practice operations, federal partnerships, and continued access to advanced medical technology. The scope of administrative modifications that I implemented included comprehensive evaluation of his $3.2 million in federal research funding, review of medical equipment allocations worth over $850,000, assessment of pharmaceutical consulting relationships, and examination of federal compliance status that determined continued eligibility for National Eye Institute partnerships and Department of Defense research coordination throughout New England's most prestigious medical research network. But perhaps the most immediate impact became apparent when the pharmaceutical executives who were attending Marcus's consultation meeting began receiving real-time notifications about compliance evaluation affecting their potential consulting partners' federal research status and medical equipment access. The professional networking that Marcus had prioritized over elderly healthcare began experiencing complications when pharmaceutical companies discovered that their potential consultants' practice was under administrative review for compliance violations. The sophisticated business presentation that Marcus had invested months coordinating became increasingly awkward as pharmaceutical executives questioned the stability and federal compliance status of a medical practice requiring ongoing evaluation and potential service modification. The $200,000 in consulting contracts that he had expected to negotiate transformed into professional embarrassment when major pharmaceutical companies discovered that their potential partners' research funding and federal relationships were under comprehensive administrative review. At 4:20 p.m., while Marcus presumably discovered that his pharmaceutical meeting had dissolved into crisis management and professional damage control, I implemented the second phase of consequences by activating emergency medical coordination protocols that affected his immediate access to federal research funding and advanced equipment support services. The administrative modifications included temporary suspension of equipment maintenance, research funding coordination, and federal partnership support that distinguished premier medical practices from standard healthcare operations. The third phase began at 5:45 p.m. when I activated comprehensive federal relationship evaluation that affected Marcus's continued eligibility for medical research funding, pharmaceutical consulting opportunities, and advanced equipment access throughout New England's most prestigious healthcare network. The systematic nature of these modifications ensured that his professional lifestyle experienced immediate complications while generating comprehensive documentation of compliance, evaluation, and administrative review requirements. But the most transformative phase commenced when I proposed something unprecedented to the federal health officials who had been monitoring the compliance evaluation. The Massachusetts Family Medical Responsibility Program, which would require Marcus to spend 18 months providing vision care services to elderly community members while learning about healthcare administration and creating medical solutions that served senior citizens, rather than excluding them from advanced vision care. The program would operate under my direct supervision as Chief Medical Coordinator, requiring Marcus to work alongside elderly healthcare professionals and community members who understood the value of traditional medical wisdom and generational respect in creating meaningful vision care solutions and community health services. The transformation that began during Marcus's community service exceeded even my own expectations for what medical education could accomplish when combined with elderly wisdom recognition and family respect restoration. Marcus's initial resistance to participating in hands-on elderly vision care gradually evolved into genuine appreciation for the senior community members we served and understanding of the administrative expertise required for effective healthcare coordination and federal compliance management. His work developing accessible vision care programs for elderly community members provided him with purpose and professional satisfaction that exceeded anything he had experienced during his exclusive pharmaceutical consulting and business advancement activities. The 18 months of Massachusetts Family Medical Responsibility Program operation created measurable community impact that included coordinating vision care services for over 450 elderly community members, providing medical education to 280 families and individuals, training 89 community members in healthcare coordination and vision care assistance, and creating ongoing support networks that continued serving elderly healthcare needs long after the formal program concluded. 3 years later, Marcus's transformation had become a model for family-based medical responsibility throughout New England, with our story featured in federal health policy journals as an example of how administrative intervention could create family healing and authentic community healthcare service. His current work coordinating the annual New England Family Healthcare Responsibility Network, which operates in 34 communities throughout the region, provides ongoing opportunities for meaningful contribution while maintaining the family relationships and elderly respect that distinguished authentic medical practice from superficial business advancement. The modest Springfield residence where Marcus now lives, purchased with assistance from a community healthcare development program, provides comfortable family living while supporting his elderly vision care work and maintaining proximity to the community members whose wisdom and support had created the foundation for his transformation. His current position as Community Vision Care Director at the Massachusetts Elderly Health Foundation, earning $145.00 annually while coordinating accessible vision services and elderly healthcare programs throughout the region, provides meaningful professional work that honors both his medical expertise and his commitment to community service and family values. Remember, federal research funding and medical equipment access aren't guaranteed professional entitlements. They're earned recognition of demonstrated character and family respect. That creates the foundation for healthcare industry credibility and authentic medical service. The research coordination that had protected Marcus's comfortable assumptions became the foundation for his transformation into a community servant who understood that true medical success comes from serving others while honoring the elderly relatives whose lifetime of expertise and service created every opportunity for authentic contribution and family legacy development. Sometimes the most valuable lesson you can teach ungrateful family members is that medical privilege isn't automatic entitlement. It's earned recognition that continues only when families demonstrate appropriate respect for elderly wisdom and traditional values that create the foundation for authentic healthcare service and meaningful medical contribution. The vision care coordination that had supported their comfortable lifestyle became the foundation for transformation into community service that demonstrated how healthcare authority and family healing could create opportunities for lasting impact and authentic professional satisfaction and service to others. Up next, you've got 2 more standout stories right on your screen. If this one hit the mark, you won't want to pass these up. Just click and check them out, and don't forget to subscribe and turn on the notification bell so you don't miss any upload from us.